As genetics and genomics become more widely dispersed, it's become clear that the rate-limiting steps are understanding what causes the disease in these individual patients and their families, and then how can we find a way to get to a drug or a therapy of some other sort as quickly as possible for these disorders. The central theme of the Cardiovascular Genetics Center at Brigham and Women's Hospital is bringing basic science directly to the patient in real time.
I have hypertrophic cardiomyopathy. I have a family history of the disease or the condition because my grandfather in the 70s died of cardiac arrest. So I've been followed since I was a kid, and I remember my first echo when I was in 5th grade.
Right now, with genetic testing, we're able to identify the genetic mutation that is responsible for causing disease in a family, and we're able to tell the family which relatives are at risk for developing the disease and which are not, by virtue of whether they've inherited the mutation or not. And that's great, but it's really not enough. The conversation that we dream of having in the future is to say, we've identified what causes HCM in the family, we know who's at risk for developing it, but if we start this treatment, nobody will develop it.
We have 2 kids now, and sort of statistically, yeah, one might have it, but neither one might, and hopefully they'll be okay, but.
We've had the benefit of having the pioneering work of the Seidman Lab under John and Cricket Seidman, and now we have 7 active clinical cardiovascular geneticists practicing in each of the broad areas of inherited heart and vascular disease. And at the same time, as managing these patients clinically, we're driving discovery to try and identify new drugs for each of those conditions.
Our lab for many years has studied cardiomyopathies, and they come in 2 different major subtypes, hypertrophic and dilated cardiomyopathies. Hypertrophic cardiomyopathy is the leading cause of sudden cardiac death on the athletic field. Dilated cardiomyopathy is a major cause of heart failure, and to date, the only definitive treatment for that is a human heart transplant surgery. Hypertrophic cardiomyopathy is largely caused by mutations in 2 different genes, the motor myosin, which allows the heart to contract, and myosin-binding protein C, which regulates contraction.
The good news is that patients with these mutations live 30 or 40 years. So it's I think a reasonable hypothesis that if we could make relatively subtle changes in the muscle physiology, that we could actually treat that disease. We don't need to make dramatic changes to solve this problem. So if we could identify a small molecule that could intervene in the contractile process, that might allow us to treat hypertrophic cardiomyopathy.
In a laboratory animal, we can test all sorts of small molecules, and those have been very beneficial and are beginning to identify new ways that we can prevent the development of cardiomyopathy or at least mitigate the progression of disease.
Now, in the last few years, we're in a position to be able to take genetically defined diagnoses and find treatments that are uniquely specific to those genetic forms of disease and try and reverse those disorders. So we have at present 4 active genotype-driven clinical trials in different forms of inherited heart disease, whether it's hypertrophic cardiomyopathy or dilated cardiomyopathy, or even some other forms of cardiomyopathy that are rarer.
I'm in what's called the VANISH trial, which is testing a medication, which as far as I understand is trying to, in a situation like mine where I was known in family history, but I didn't have it yet, prevent it from manifesting itself. And then I think also being able to, if it were already manifested, trying to mitigate the growth that could happen from it.
We start with patients, we figure out what causes the genetic basis of their disease, we designed mechanistic studies to understand, and then we bring that information back to driving therapies that we can return to those very same precise patients.
The synergy between sort of basic science and clinical medicine works very well for us. And it certainly, there are not many people who've had the opportunity to have this, or even many institutions that can provide this close type of interaction.
I'm very fortunate and lucky to be nearby and be able to access the Brigham and all the care here.
Fundamentally, the goal is to have the treatment fit the disease, to have the right treatment in the right patient. And in order to do that, we believe you need the right team. And that's what we've been trying to build here at Brigham and Women's.